Bismillah ar-Rahman ar-Rahim. Our talk today will be about glomerular disease, overview of glomerular disease. We will try to make this discussion MRCP oriented as much as possible for both MRCP part 1 and MRCP part 2. I hope my voice is clear. If at any moment I got disconnected or my voice became unclear, please inform me.
Definitely we'll know you know, Dr. Khalid.
Okay. So we will start immediately. Before going into details of glomerular disease or glomerulonephritis, first I would like to highlight some few points related to the basic physiology and basic histology of the kidneys. So as we all know, the nephron is the functional and structural unit of the kidney. And the structure of the nephron is basically made of two main parts. We have number one, the glomerulus, and number two, we have the renal tubules. The glomerulus is also called the renal corpuscle. The renal corpuscle is consisting of the glomerulus and the Bowman's capsule, which is enclosing the glomerulus. So when you look here at the glomerulus, at the structure of the glomerulus, you will find that you have a tuft of capillaries. These are glomerular capillaries. And here we have afferent arteriole, and this is the input of blood into the glomerulus. Then we have the efferent arteriole, and this is the output of the blood from the glomerulus. The tuft of capillaries, the glomerular capillaries, are enclosed within a special capsule called Bowman's capsule. This Bowman's capsule has two layers. It has an outer layer called the parietal layer. It's an epithelial layer. As you can see here, this is the outer layer of the Bowman's capsule, which is called the parietal layer. Then we have an inner layer, which is called the visceral layer. The visceral layer of the Bowman's capsule is tightly attached to the glomerulus. It's attached to the glomerular capillaries. And this inner layer, which is attached to the glomerular capillaries, is called the visceral layer, and it's made of podocytes. These are specialized epithelial cells called podocytes. So basically, the glomerular capillaries play an important role in formation of the filtrate. The glomerular filtration is coming out of these glomerular capillaries, and it's secreted into the space here. This space is between the outer layer and the inner layer of the Bowman's capsule, and this is called the Bowman's space. This is where the filtrate will be formed and where the filtrate will be released from the glomerular capillaries. This filtration of plasma fluids into the Bowman's space here depends on the three layers which are lining the glomerular capillaries. We have three layers lining the glomerular capillaries. The innermost layer is called the endothelium. This is the capillary endothelium. The outer layer is called the podocytes, which is the visceral layer of the Bowman's capsule, as we mentioned. Between the podocytes and the endothelium, we have the glomerular basement membrane. So these are basically the three layers forming the membrane of the glomerular capillaries. And this membrane is called glomerular filtration membrane. This membrane is very important because it forms the renal blood barrier. This is what determines what should go out and what should be kept in the circulation. This will determine what are the molecules and substances which will be released into the filtrate here and eventually can appear in the urine. So the inner layer is made of the endothelial cells. Then outside the endothelial cells, we have the glomerular basement membrane. Then outside the glomerular basement membrane, we have the epithelial layer, which is made of the podocytes, as we mentioned. So these are the three layers of the glomerular filtration membrane. These three layers provide an important barrier for substances in order to pass into the urine, into the filtrate here. Not any substances in the blood can pass into the filtrate. As we know, the blood is consisting of blood cells and plasma. The blood cells should never cross the glomerular filtration membrane due to the size of the cells. But plasma, components of the plasma, some of the components of the plasma can pass into the filtrate here. And what determines which components of the plasma will pass is the glomerular filtration membrane, as we said. This glomerular filtration membrane provides two types of barrier. Number one, we have size barrier, and number two, we have charge barrier. The size barrier, meaning that in order for any substance from the plasma to pass into the filtrate, it must have the adequate and the right size, which allows it to cross the size barrier provided by the glomerular filtration membrane. And along with the size barrier, also we have charge barrier. There are negatively charged molecules located in the glomerular basement membrane and on the podocytes. And these negative charge molecules will provide charge barrier for the substances in the blood. That means that negatively charged molecules will not pass. It will be repelled due to the negative charge on the membrane. So in order for any substance, any molecule from the blood to enter the filtrate, this molecule should be either positively charged or it should be neutral. And in that way, it can cross the charge barrier. So for any substance to cross the charge, to cross the filtration membrane and to enter the filtrate, number one, it must have a norm, it must have an ideal size to cross the size barrier. And number two, it should have also an ideal charge in order to cross the charge barrier. So this is how important is the layers of the glomerular filtration membrane. Here also, between the capillaries in yellow, as you can see, we have an important cells. These cells are called mesangial cells. These mesangial cells also has an important role. These cells can either contract or relax. It can regulate the blood flow. The blood flowing into the glomerulus can be controlled by these cells. And since it controls the blood flowing into the glomerulus, that means it can control and regulate the glomerular filtration rate, because the glomerular filtration rate, it depends on the blood flow into the glomerulus. So these cells are very important physiologically and also pathologically speaking, because in certain types of glomerulonephritis and certain types of glomerular disease, these cells will express some pathological changes. It will become, they will have mesangial expansion. The number of these cells will increase. These cells also has the ability to release and to form an extracellular matrix. And there are pathological changes which will develop in these mesangial cells in certain types of glomerular diseases, as we will talk later on. So these are just basic points and basic concepts. So as you can see here, this picture might show the glomerular filtration membrane in a better way. This is the capillary lumen, and here we have the Bowman's space. The filtrate should go from here into the Bowman's space. In order for the substances to cross, to go from the capillary lumen into the Bowman's space, it must cross these three layers, which are forming the glomerular filtration membrane. The inner layer is called the endothelium, as we said. The middle layer is called the glomerular basement membrane, and the outer layer is the epithelial layer, which is made of the podocytes. As you can see, the endothelial cells and the endothelial layer is fenestrated. There are fenestrations on the endothelial layer, and that means this layer is porous. There are pores, and these pores is around 70 to 100 nanomole. So in order for substances to cross this layer, it must have the same size and have the right size to be crossed this 70 to 100 size barrier provided by the endothelial layer. Then we have here the glomerular basement membrane, and as we said, there are negatively charged molecules here on the glomerular basement membrane, and also we have negatively charged molecules on the podocytes. And these negatively charged molecules will provide a charge barrier against the substances in the blood. So not only we have size barrier determined by the pores in the endothelial layer, but also we have charge barrier offered by the glomerular basement membrane and the podocytes, which are present here. These podocytes, these epithelial cells, they have characteristic food processes, and these food processes through which it can attach to the glomerular basement membrane. And between these food processes, there are also what is called filtration slits. And these filtration slits also some sort of size barrier as well in the glomerular filtration membrane. And it's narrower compared to the pores in the endothelium. So the substances should not just have an adequate size to cross the endothelial layer, cross the pores on the endothelial layer, but should have an appropriate size also to be able to pass through these filtration slits. So also the podocytes will give you size barrier also. It will contribute in the size barrier along with the endothelium. So this is the basic structure of the glomerular filtration membrane. This is another figure also. It's a cross section here, as you can see. This is the glomerular stuft. And around it, we have the Bowman's space where the urinary filtrate will be formed. And this is the Bowman's capsule enclosing the glomerulus. As we said, this is the parietal layer, which is outside. And the inner layer, which is attached to the capillaries, is called the visceral layer, and it's made of podocytes, which form part of the filtration membrane. So as you can see here again, this is the capillary lumen here. These are the endothelial cells which are fenestrated. There are pores. And then this is the basal membrane. And here we have the podocytes with their food processes. And as we said, there are filtration slits between these podocytes, which also contribute in the size barrier. So I hope till now everything is clear. So we can proceed to the pathology.
Very clear
to everyone.
Very clear, yeah. Thank you.
Okay. So after talking about these basic points, let's try to apply it clinically
دكتور
in the
خالد
pathology.
البودوسايت هي من الفيزرال لاير ولا من الجلوميرا نفسها اللي عنده الابيثيليا حق الجلوميرا
Here,
البودوسايت
epithelial layer from the Bowman's capsule. The Bowman's capsule has an outside layer, which is called the parietal layer, and has an inner layer, which is called the visceral layer. The epithelial cells forming the visceral layer are called podocytes.
اوكي
And it's the outermost part of the glomerular filtration membrane. As here it's very clear from outside. You can see these are the podocytes.
اوكي
So when we talk about glomerular diseases in general and glomerular injury, we will not discuss it in the conventional textbook matter when you discuss any disease. We will not go through the definition, etiology, and then the pathogenesis, and then after that, the clinical features, and so on. What we will do is we will try to understand it in a reversed fashion. This will make it more clear. First, we will talk about the clinical manifestations of glomerular injury. What are the types of clinical syndromes and the types of clinical features that can develop whenever you have any sort of glomerular injury? Then after that, we will talk about the pathogenesis, the mechanisms by which glomerular injury will develop. Then we will talk about the different types of glomerular diseases or glomerulonephritis. And then at the end, we will mention the possible etiologies for the glomerular injury. So we will study it in the reversed fashion. So the clinical manifestations of glomerular injury, it can be variable, and it depends on the severity and the degree of injury and the duration of injury, for how long this injury is persisting, and the degree of injury, how severe this injury. So according to that, we can have 6 main types of clinical manifestations. Number one, in the mildest forms of injury, if you have a very mild injury to the glomerulus, the initial presentation can be with asymptomatic subnephrotic range proteinuria. So these patients will be asymptomatic. They will release protein into their urine. They will have proteinuria, but this proteinuria is not to the nephrotic range. The nephrotic range of proteinuria is more than 3 grams per day, as we know. But in the mildest form of injury, the patient will have proteinuria, but it will be subnephrotic range. It will be less than 3 grams per day. For example, it can be 1 gram or 1.5 gram, less than 3 grams per day. This will be called subnephrotic range proteinuria. And since the proteinuria is subnephrotic range, for that reason, the patient will be asymptomatic, because in order for proteinuria to cause symptoms, it should be more than 3 grams per day. It should be nephrotic range proteinuria. Only at that point, you will have the symptoms of nephrotic syndrome. But before developing nephrotic syndrome, the injury can be mild, and it can only lead to subnephrotic range proteinuria, and the patient will be asymptomatic. This proteinuria can be selective proteinuria, or in some cases, it can be non-selective proteinuria. So what do we mean by selective or non-selective proteinuria? Selective proteinuria basically means this proteinuria is made only of albumin. there is selective, this proteinuria is selective for albumin only. So the patients will have albuminuria, but other types of plasma proteins would not be detected in the urine. Because albumin has small molecular weight when you compare it to other plasma proteins. When you compare albumin with fibrinogen, for example, or with globulins, you will find that albumin is smaller compared to these types of proteins. So in certain types of glomerular diseases, you will have proteinuria, and this proteinuria will be selective albuminuria. It will be selective proteinuria. It will be only albuminuria. But in other cases, the proteinuria will be non-selective. So you will have albumin along with other types of plasma proteins secreted in large amounts in the urine. So why do some people develop selective proteinuria and others develop non-selective proteinuria? In selective proteinuria, it means that the patient is having a very mild glomerular injury, which has not disrupted the size barrier, but it has disrupted the charge barrier. So if you have a very mild glomerular injury, the size barrier might not be disrupted. It will remain the same normally, but there might be changes in the charge barrier in the glomerular basement membrane. And this is classically seen in a disease called minimal change disease. In minimal change disease, there are some autoreactive T cells, autoreactive T lymphocytes. These autoreactive T lymphocytes will release certain types of cytokines, inflammatory cytokines. And these cytokines what will do is it will neutralize the negative charge on the glomerular filtration membrane. It will simply reduce the negative charge on the glomerular basement membrane. And hence you will have less size, you will have less charge barrier, but the size barrier will remain intact. And in these circumstances, when you have a disruption in the charge barrier, here you can leak albumin into the urine. Albumin can start leaking into the urine. You will have albuminuria because the size of albumin is just enough to allow it to pass through the size barrier. So albumin, by its size, can cross the size barrier because it has a very small size compared to other plasma proteins. But what prevents albumin normally, physiologically, from passing into the urine is the charge barrier, not the size barrier. And if you lost the charge barrier due to any pathological reason, then at that point, albumin will start leaking into the urine in large amount because albumin has no problem with the size barrier. It has just the right size to cross the glomerular basement membrane, to cross the glomerular filtration membrane. But the problem was with the charge. And since the charge here is impaired, you have less negative charge on the membrane. That means albumin can start leaking into the urine. And you will end up with selective proteinuria. The proteinuria will be made of albumin only. And this selective proteinuria in the early part of the disease will be subnephrotic range. It will be less than 3 grams per day. So the patient will be asymptomatic. So this is the mild form of glomerular injury. Then next, let's suppose there is more severe degree of injury. Or let's suppose the previous patient who had asymptomatic subnephrotic range proteinuria and was asymptomatic. In this patient, the disease became a little bit more advanced. There is more injury to the glomerulus. Then this patient will convert from the first clinical manifestation to the second clinical manifestation. The proteinuria will become nephrotic range proteinuria. So the patient will have nephrotic syndrome. The patient will have proteinuria more than 3 grams per day. So we'll develop the complete clinical picture of nephrotic syndrome. And again, this nephrotic syndrome can also be selective proteinuria or non-selective proteinuria. And depends again on the type of injury. If this injury is disrupting the size barrier as well as the charge barrier, then you will have non-selective proteinuria. But if the injury is only impairing the charge barrier without affecting the size barrier, then you will end up with selective proteinuria. So the term selective or non-selective proteinuria will just tell you, and it will just give you the impression about the type of glomerular injury you are dealing with. So in nephrotic syndrome, what happens is there are more than 3 grams per day losses of proteins into the urine, and this is called heavy proteinuria. And this heavy proteinuria, this heavy losses of protein to the urine will lead to hypoalbuminemia. The protein level in the blood will become depleted. You will have hypoproteinemia and hypoalbuminemia. So you have low albumin, and this hypoalbuminemia will reduce the plasma oncotic pressure. And this reduction in the plasma oncotic pressure will eventually lead to generalized edema, as we know. And as we know, in nephrotic syndrome, the edema characteristically tend to start in the periorbital area and then tend to become generalized, which is called an asarca. And even it might involve the pleural spaces. Sometimes you can have pleural effusion. There might be ascites as well. So you will have generalized body edema, and this is related mainly to hypoalbuminemia. But there is another mechanism also contributing to edema. We will talk about it now. But before that, also, along with edema, the patient also will have dyslipidemia, because when there are large and there are heavy losses of proteins into the urine, there is heavy proteinemia, proteinuria, the liver will start to compensate. As we know that the main synthetic site in the body for proteins is the liver. So the liver will start compensating for the losses of proteins into the urine by producing different types of proteins, including LDL. So the levels of LDL in the blood will increase, and this will automatically lead to hyperlipidemia or dyslipidemia. And this is one of the complications associated with nephrotic syndrome. So these are the four main components of nephrotic syndrome. Edema, as we said, is mainly related to hypoalbuminemia, which will lower the plasma oncotic pressure, but also edema, it can be due to salt and water retention, which can also happen in patients with nephrotic syndrome, because when there is hypoalbuminemia, the fluids, there will be transudation of plasma fluids into the extravascular compartments. And this transudation and this shifting of fluids into the extravascular compartment will lead to hemoconcentration. And this hemoconcentration will impair the tissue perfusion, especially the kidneys. The kidneys will become hypoperfused. So you will have renal hypoperfusion to some degree in patients with nephrotic syndrome. This renal hypoperfusion, as we know, it will immediately activate the renin-angiotensin-aldosterone system. So the patient will have secondary hyperaldosteronism. And this secondary hyperaldosteronism will lead to sodium and water retention. So sodium and water retention will increase the plasma hydrostatic pressure. And this increase in the hydrostatic pressure also will contribute in the formation of edema. So this edema in nephrotic syndrome is not just related to hypoalbuminemia and reduction in the plasma oncotic pressure, but it also related to sodium and water retention and increase in the hydrostatic pressure. So these are the main problems seen with nephrotic syndrome. The complications of nephrotic syndrome are not just limited to these things. When we lose proteins into the urine into large amounts, there will be losses of important plasma proteins like complement proteins, for example, and immunoglobulins. So these losses of complement proteins and immunoglobulins will make the patient prone to infections. So you will have immunoparesis, you will have immunosuppression, some degree of immunosuppression in patients with nephrotic syndrome. And these patients will be prone to develop recurrent infections. And this is one of the main complications with nephrotic syndrome, especially infections related to encapsulated organisms like pneumococcal, meningococcal infection, and so on, because these encapsulated organisms require an intact and potent complement system. If you are losing complement proteins into the urine, this will increase the risk of infection, especially with encapsulated organisms, but also infection with other different types of organisms. So this is one of the serious complications related to nephrotic syndrome, infections. Another complication is hypercoagulability. Patients with nephrotic syndrome, they tend to have a prothrombotic state. They can develop venous thromboembolism. They can present with DVT, for example. They can present with renal vein thrombosis even. They can present with Budd-Chiari syndrome, with cerebral venous thrombosis, and so on, because they have hypercoagulable state. This hypercoagulability of the blood in nephrotic syndrome is due to two main reasons. The first reason is due to the excessive loss of endogenous anticoagulant proteins into the urine as part of the proteinuria. As part of the heavy proteinuria, you will have losses of some endogenous anticoagulants like antithrombin 3 or like protein C, for example. So these losses of antithrombin 3 will lead to hypercoagulable state because these are endogenous anticoagulants. This is one of the reasons. Another reason is due to the hemoconcentration that develops in these patients. As we said, the hypoalbuminemia will lead to transudation and extravasation of plasma fluids into the extravascular compartments, and this will lead to hemoconcentration. This hemoconcentration will cause blood stasis, and it can also predispose to thromboembolism. So this is another serious complication in patients with nephrotic syndrome. So patients with nephrotic syndrome are prone to infections, and they are prone to thromboembolic complications as well. So That's all about the clinical features related to nephrotic syndrome. So as we said, here the injury is more severe than the first patient. The numbering here is according to the severity of the injury. In the first patient, the patient is having the slightest degree of injury. Let's hypothetically say that the patient here is having first degree injury. Then in nephrotic syndrome, the patient is having more severe degree of injury. It might be a progression from the first patient, or the patient from the beginning might present with nephrotic syndrome, depending on the severity of injury. Then after that, in more severe cases, if the injury to the glomerulus is more severe and there is more pronounced inflammation in the glomerulus, in the first two patients, in the asymptomatic patient and patient in nephrotic syndrome, on examination under microscope, when you examine the biopsy specimen, you might not detect significant inflammatory changes in the glomerulus. And sometimes you might not even detect any inflammatory changes, like a minimal chain disease. But if the injury is more severe and there is more inflammation, more pronounced inflammation in the glomerulus, the picture will change. The clinical presentation will be different. And the patient can develop something called nephritic syndrome. In nephritic syndrome, it means there is more severe injury, there's acute inflammation. And the patient will present with acute presentation. Unlike in nephrotic syndrome and in subnephrotic range proteinuria, the patient here is asymptomatic. In nephrotic syndrome, the patient might have an insidious onset. There might be subacute presentation and sometimes chronic presentation. But in nephritic syndrome, the presentation is acute presentation because there is severe inflammation. There is an acute inflammation damaging the glomerulus. And this acute inflammation would not just affect the charge barrier as in minimal chain disease, it will affect the whole glomerulus. It will impair the size barrier as well as the charge barrier. It will damage the glomerular filtration membrane. The whole glomerular filtration membrane will be damaged by this acute inflammation, and the patient will develop something called nephritic syndrome. So what are these features of nephritic syndrome? First, the patient will develop microscopic hematuria, because in nephritic syndrome, when we talked about nephrotic syndrome first, in nephrotic syndrome, the damage is severe enough in the glomerulus, damage in the glomerulus is severe enough to allow passage of plasma proteins only. But still, the blood cells will not pass because the size of the blood cells is much larger compared to the plasma proteins. So in nephrotic syndrome, because the pathology is less severe compared to nephritic syndrome, in nephrotic syndrome, only the plasma proteins will leak, but the blood cells will remain intact in the blood. But in nephritic syndrome, because there is too much damage to the glomerulus, there is too much inflammation, not only plasma proteins will leak, but also blood cells will start leaking into the urine. Blood cells will start leaking into the filtrate. So you will have microscopic hematuria. You will start to develop red blood cells into the urine, which will be detected under microscope. The hematuria of glomerular injury, it will not be gross hematuria. It will not be seen with the eyes. It will be microscopic hematuria. It's different than the hematuria related to urological conditions like stones and tumors and so on. It will be microscopic hematuria. Along with this microscopic hematuria, the red blood cells, which will be released into the urine, some of these red blood cells will have an abnormal morphology. It will be called dysmorphic red blood cells. Because these red blood cells, in order to enter the filtrate here, in order to cross from the capillary lumen to enter the filtrate here, it should pass through a disrupted and distorted glomerular filtration membrane. And then it will enter the urinary space, you enter the Bowman's space here, and then it will pass into the renal tubules, where the lumen and the diameter is very narrow for the red blood cells. So these red blood cells, when it passes from the Bowman's space here into the renal tubules until it reaches eventually the urinary tract, it will pass through narrow passages and distorted passages, and this will damage the red blood cells membrane, will damage the membrane of the red blood cells. So these red blood cells will lose its normal morphology and will become a dysmorphic, or red blood cells of abnormal morphology, and will start appearing into the urine. So when you detect microscopic hematuria in any patient, you need to look for the dysmorphic red blood cells. If you are thinking of glomerular origin of hematuria, if you are considering this hematuria to be of glomerular origin, not just enough to have microscopic hematuria, you also need to have dysmorphic red blood cells. This will give you the indication that these RBCs are not coming from the lower urinary tract. It's not due to urological problem. These red blood cells are coming from the glomerulus. This is hematuria of glomerular origin. So microscopic hematuria along with dysmorphic red blood cells. These are characteristic features in nephritic syndrome. Along with that also, these patients will start to have oliguria. The urine output will be reduced. You have less than 0.5 ml per kg per hour urine output. And this oliguria is due to interruption of the blood flow through the glomerulus. When there is an inflammatory microenvironment in the glomerulus here, this will interrupt the flow of blood into the glomerulus. The blood will not pass smoothly as in the normal circumstances because there is inflammation, and this inflammation will lead to injury to the endothelium, and this injury to the endothelium will activate the platelets and coagulation system. There will be platelet aggregation and deposition at the site of endothelial injury. So there will be platelet plug formation within the microcirculation here. And this formation of platelet, along with activation of coagulation system, along with infiltration of this area with inflammatory cells like neutrophils, all these factors will impede the blood flow across the glomerulus. So we'll have reduced blood flow in the glomerulus, the glomerular capillaries. And since the blood flow here is reduced, automatically the glomerular filtration rate will be reduced. When you have less blood flowing here, that means you have less filtrate coming out. So you will have less glomerular filtration rate, and you will have less urine output. So nephritic syndrome will give you oliguria. The patient will start to have low urine output. And this is one of the main features in nephritic syndrome. Along with the oliguria, also you have azotemia. Azotemia is the term which indicates asymptomatic elevation in urea and creatinine. If you have an asymptomatic elevation in urea and creatinine, this will be called azotemia. But if this elevation in urea and creatinine is causing symptoms like symptoms of uremia, for example, or symptoms of fluid overload, at that point you will call it uremia. You will not call it azotemia. And at that point, the patient will be called to have renal failure. But azotemia, simply, this term indicates that you have just an elevated creatinine and elevated urea, and the patient is asymptomatic. And this is very important in order to differentiate nephritic syndrome from acute kidney injury, because one of the possible clinical manifestations in glomerular injury is acute kidney injury. Nephritic syndrome is a stage before acute kidney injury. When you have just elevation in creatinine and urea, but without causing complication of renal failure, this, along with the other features, microscopic hematuria and so on, this will be labeled as nephritic syndrome. So oliguria associated with azotemia. This azotemia is also related to oliguria. If the glomerular filtration rate is reduced, automatically that means the metabolic waste products of the blood, which should normally be excreted through the kidney, these metabolic waste products will not be excreted in a normal way, and so it will start building up in the blood. So you will have high urea and high creatinine in the blood. This is called azotemia. Then another feature is hypertension, and this is also related to oliguria, again, because the kidneys has important physiological actions. Beside the excretory function of the kidney also regulates the fluid balance in the body. So if there is low urine, if there is low glomerular filtration rate, if there is oliguria, that means the ability of the kidney to handle fluids will be impaired. So you will have salt and water retention. And this salt and water retention will cause hypertension. So hypertension is one of the serious complications related to nephritic syndrome, and it will not be seen with nephrotic syndrome. Finally, in nephritic syndrome, you will have mild degree of proteinuria, which means it will be subnephrotic range proteinuria. And this seems a little bit paradoxical, because since we said that nephritic syndrome means more severe injury compared to nephrotic syndrome, so why do patients with nephritic syndrome, they tend to have less proteinuria compared to nephrotic syndrome? This is paradoxical, but it's simply related to the extensive inflammation in nephritic syndrome, which will impair the blood flow to the glomerulus and which will reduce the glomerular filtration rate. As we said, since there is less blood flow in the glomerulus in nephritic syndrome and there is less glomerular filtration rate, logically that means you will have less filtration of protein. So despite that, the membrane integrity, the glomerular membrane integrity is impaired, the size and charge barrier are all impaired, but despite that, still you will not have significant losses of protein to the urine in patient with nephritic syndrome. And this is simply due to the fact that the blood is flowing less in the glomerulus in these patients. There is inflammation, which impeding the flow of blood into the glomerulus and impairing the glomerular filtration. And hence you will have less filtration of protein. So you will have proteinuria, but it will be mild degree of proteinuria. It will be subnephrotic range, less than 3 grams per day. And this is one way to differentiate nephritic from nephrotic. If you have all the features of nephritic syndrome, but there is proteinuria more than 3 grams per day, at that point, the patient would be considered to have nephritic mixed with nephrotic syndrome. There's something called nephritic syndrome. But in just nephritic syndrome, you will have proteinuria subnephrotic range, less than 3 grams per day. So these are the differences between nephritic and nephrotic syndrome. Before the patient go on to develop nephritic syndrome, before developing this full picture of nephritic syndrome, initially the patient might only just have microscopic hematuria without the other features in the early part of nephritic syndrome. So you might come across a patient with glomerular injury presenting only with asymptomatic microscopic hematuria. But this is more serious. This is more serious than asymptomatic proteinuria, subnephrotic range proteinuria, because here, this asymptomatic microscopic hematuria, if it's of glomerular injury, it might indicate the beginning of serious glomerular disease. And this patient might progress from here into nephritic syndrome. So before presenting with nephritic syndrome, the patient might initially have asymptomatic microscopic hematuria. So not any hematuria detected in the urine test, if you have done urine test, regular or routine urine test to anyone, and you found that there is asymptomatic microscopic hematuria, not any asymptomatic microscopic hematuria is due to some urological problem, not just due to stones or something like that. Sometimes this microscopic hematuria might indicate actually a glomerular disease, which could be in its early stage, and in the future, this glomerular disease might progress into something more serious, and the patient might later on might develop nephritic syndrome or go on to develop renal failure in later stages. So these are possible ways of clinical manifestations in glomerular injury. Then we have some patients, some unfortunate patients due to glomerular injury. If the injury is so severe, more severe than in nephritic syndrome, at that point, these patients might present with an acute kidney injury. And these patients, maybe initially, they might start as asymptomatic microscopic hematuria, then they will become nephritic syndrome, and eventually they will progress into acute kidney injury. Or from the beginning, they will present with acute kidney injury immediately. And this depends on the severity of the glomerular disease. As we will talk later on, there are certain types of glomerulonephritis in which there is high risk to present as acute kidney injury. There are some types of glomerulonephritis which can present from the beginning with acute kidney injury, while there are other types which can present with nephritic syndrome. There are some types which can present only with nephrotic syndrome or even with subnephrotic range proteinuria. We will try to differentiate between these different types of glomerulonephritis. Finally, glomerular injury can present as chronic kidney disease. And this can be the outcome of any one of the previous manifestations that we talked about. If any one of these 5 manifestations that we have discussed, if any one of these persisted and became unresolved and not controlled, eventually it can end up in chronic kidney disease. Consider this as a basket, which will be the outcome of any one of these 5 scenarios. If these scenarios are not controlled, if these scenarios are considered unresolved and persistent. So if the cause of injury is persistent and it's chronic and it's long-standing, and if it's not controlled by treatment or anything, or not resolved spontaneously, eventually it can end up with chronic kidney disease. And there are certain types of glomerulonephritis, certain types of glomerular diseases, which has a tendency to progress into chronic kidney disease. So these are the basic types of clinical manifestations of glomerular injury. So whenever you have a glomerular disease, it can present with any one of these main manifestations. And it's not necessarily to be in that order. The patient might present from the beginning with AKI, or the patient might be caught, at the time of the diagnosis, the patient might be already having CKD. But it might mean that this patient for years, maybe this patient with CKD for years or for months, he has been suffering from subnephrotic range proteinuria, but it was undetected and unnoticed. Or maybe it might not necessarily to become nephrotic syndrome. It might be chronic asymptomatic subnephrotic range proteinuria for a long time, until eventually it presents as chronic kidney disease. And the classical example here is diabetic nephropathy. In diabetic nephropathy, the patient will have microalbuminuria for a long time before eventually progressing into chronic kidney disease and become end-stage renal disease. There is an interesting point I would like also to highlight here regarding nephrotic syndrome. The patient, by definition, nephrotic syndrome means heavy proteinuria, which means more than 3 grams per day. As we said, whenever there is proteinuria, the liver will start to compensate. The liver will try to compensate these losses of proteins. And actually, the liver capacity, the ability of the liver to produce proteins is very high. The liver can produce up to 25 grams, it might reach up to 25 grams per day of protein. So you might ask yourself a question, if the liver able to produce up to 25 grams per day of protein, it should be easily able to compensate these losses of more than 3 grams per day. For example, if you have a patient with nephrotic syndrome with 4 grams per day losses, since the liver can compensate, since the liver can produce up to 25 grams per day, then it should be able to compensate for these losses. But this is actually not accurate, because the losses into the urine, the losses which you can collect during the 24 hours, when you do 24-hour urine collection for proteinuria, and you find out that there is, for example, 4 grams or 5 grams per day losses, this is not actually the whole losses. The amount of proteins which are filtered here, which are released into the filtrate, is much larger compared to the proteins which will appear into the urine eventually. And these proteins which are secreted here in the filtrate, not all of it will appear into the urine, because some large portion of this protein will be taken by the proximal tubular cells, the epithelial cells lining the proximal convoluted tubules. These epithelial cells can uptake part of these proteins which are released by pinocytosis or endocytosis, and these proteins, it will undergo degradation intracellularly within these proximal cells, and eventually these proteins will be reabsorbed into the blood as peptides. So yeah, the proteins which are released and secreted into the filtrate, large portion of it will be taken by the proximal cells, and it will be destroyed locally inside these proximal cells, so it will not appear into the urine. So when you have 4 grams per day losses of protein to the urine, this is actually much less compared to the total losses of proteins per day, because there are losses which we are not focusing on, taken by these cells in the kidney and not appearing into the urine. So the condition is very serious. So you're not just losing 4 grams or 5 grams per day. There are much more losses we don't see in patients with nephrotic syndrome. Any questions so far before we go to the next section?
I just would like to ask about the term of isothemia, Dr. Khalid. Does it need to be significant elevation of urea and creatinine to call it isothemia, or it could be used even if there is like mild elevation?
No, any elevation in urea and creatinine combined with the other features, it's considered as azotemia in nephrotic syndrome. If it becomes significant elevation, then at that point, the patient might have acute kidney injury and you have features of uremia. There might be a transition from nephrotic syndrome into acute kidney injury.
Okay, well, and we understand that is hematuria is indication of severity more than proteinuria. Is that right?
Hematuria, actually, it indicates that there is more significant inflammation. When you have hematuria, when you compare it to proteinuria, hematuria indicates more severe inflammation and more acute condition. Proteinuria, it might also indicate something serious. It might indicate that the patient is going on to develop chronic kidney disease, which is also serious.
Okay, thank you.
So let's talk about the pathogenesis of glomerular diseases, the mechanisms by which glomerular disease and glomerular injury can develop. There are 3 basic mechanisms. The first mechanism is deposition of circulating immune complexes in the glomeruli. In this mechanism, what happens is, as we know in glomerular diseases, there is a glomerular injury, and this glomerular injury is due to some sort of inflammation. Inflammation in glomerulonephritis is always due to some immunological process. There is some autoimmunity in glomerular diseases. These immunological reactions and immune-mediated inflammation in glomerular disease can be due to three main mechanisms. The first mechanism is the position of circulating immune complexes in the glomeruli. Circulating immune complexes means that there are some soluble antigens, there are soluble and free antigens present in the blood, and the immune system has reacted against these antigens, and the immune system started producing some antibodies. These antibodies could be IgG or it could be IgM. Then these antibodies will start binding and interacting with these soluble free antigen in the blood. So they will form these circulating immune complexes in the blood. These circulating immune complexes are very small, and they can pass through the endothelial layer, through the pores in the endothelial layer, and they can enter and get deposited within the glomerular wall. So you will have deposition of immune complexes in the glomeruli, and these immune complexes are originally formed in the blood. And then these immune complexes, when it gets trapped and deposited in the glomerular wall, it has a tendency to activate complement immediately. It will activate complements, and the patient will have complement-mediated injury to the glomerulus. The complements will start mediating the inflammation. There will be recruitment of inflammatory cells. Neutrophils will start infiltrating the glomerulus. There will be also complement-induced cell lysis. So you will have an inflammation which is mediated by these immune complexes, which has led to activation of complement proteins. This is one of the possible mechanisms by which glomerular disease can develop. The question is from where we can get this antigen. What is the antigen which is forming part of the immune complexes here? This antigen can be some endogenous antigen. It can come from an endogenous source, or it can be an exogenous antigen, extrinsic antigen. The intrinsic antigen, which can cause this mechanism, is classically seen in patients with autoimmune diseases like SLE. In SLE, there is an increased cellular apoptosis, an increased rate of cellular necrosis and cellular apoptosis. And this apoptosis, an accelerated apoptosis, will lead to release of some nuclear materials into the blood. Some of these nuclear materials, which are released from the dying cells in patients with SLE and with other autoimmune diseases, these nuclear materials will act like an antigen to which the immune complexes will react, and it will form antibodies, which will eventually lead to formation of these immune complexes. And this is classically seen in patients with systemic lupus erythematosus. These immune complexes are made of nuclear antigens like double-stranded DNA, for example, reacting with antibodies, and eventually these immune complexes will get trapped into the glomerular wall, and it will trigger inflammation, which is mediated by the complements. So here you will have consumption of complements, because complements are heavily consumed in this inflammation. You will have necrotizing vasculitis at the site of deposition in the glomeruli. And this necrotizing vasculitis will consume large amount of complements, so you will have hypocomplementemia in the blood. That's why you have low C3 and C4 levels, for example, in the blood. So this is the first mechanism. Sometimes the antigen might not come from inside the body. It might be extrinsic antigen. For example, a drug. Patient might ingest certain drug, and this drug might act like an antigen in the blood, and it might lead to formation of immune complexes. Or this antigen might be some sort of infection, could be infectious antigen. And this is classically seen in a condition called post-streptococcal glomerulonephritis. The patient will suffer from an streptococcal infection, upper respiratory tract infection, for example. Then 1 to 2 weeks or 1 to 3 weeks later, the patient will start to develop glomerulonephritis. And this is due to the streptococcal antigen, which is present freely in the blood, to which the immune system will react and will form immune complexes. And these immune complexes can get trapped within the glomerular wall, and it can lead to glomerulonephritis. So this is one of the main mechanisms by which glomerular injury and glomerular disease can develop. Another mechanism is antibodies directed against antigens on the glomerular capillary membranes. In this scenario, there are no free and soluble antigens in the blood. You will not have antigens circulating free and insoluble antigens in the blood. Here, the antigen is actually fixed antigen, and this fixed antigen is located in the glomerular filtration membrane, in one of the layers of the glomerular filtration membrane, in the endothelial or in the basement membrane or in the podocytes. There is a specific antigen which is fixed to the glomerular basement, to the glomerular filtration membrane, and the immune system will recognize this antigen as a foreign antigen, and it will start producing antibodies. These autoantibodies will be directed against this antigen, and it will interact with the antigen at the site where the antigen is present. And so it will form complexes at the site of injury. Yani the complexes are not in the circulation and then it will get trapped. Here, the complexes will be formed at the site of the antigen present within the glomerular filtration membrane. The classical example here is in anti-GBM syndrome, in a condition called good pasture syndrome. In good pasture syndrome, it's an autoimmune disease in which there are antibodies directed against type 4 collagen, which is present in the alveolar basement membrane and in the glomerular basement membrane. So in good pasture syndrome, the antigen is actually normal part of the type 4 collagen that is present in the alveolar basement membrane in the lungs and in the glomerular basement membrane in the kidney. But the immune system, due to some dysregulation and loss of the self-tolerance, the immune system will form antibodies which will be directed against this normal part of the glomerular basement membrane, and this will eventually lead to glomerular disease. So this is an example of this mechanism in good pasture syndrome. Another example is, as we said previously, the soluble antigens here, which are present in the blood in the first mechanisms, like drugs or like infection, sometimes these antigens, like drugs or infection, or even nuclear antigens as in SLE, it might not form complexes in the circulation. This antigen might go immediately into the glomerular filtration membrane. It might cross the endothelial layer, and the antigen itself can get trapped within the glomerular wall. And then the antibody will follow the antigen into the glomerular wall, and it will start the inflammation at the glomerular wall. So under these circumstances, the mechanism will be considered like this. It will be like the second mechanism, not the first mechanism. So the interaction between the antigen and antibody might happen in the blood, or it might happen at the glomerular wall. The first scenario, where there is circulating immune complexes, and then it will get trapped in the glomeruli, this is an example of type 3 hypersensitivity reaction. And this is an important concept in immunology. Hypersensitivity reaction are immune-mediated tissue damaging reactions. We have 4 main types of hypersensitivity reactions. The first 3 types are antibody-mediated. In the first scenario here, this is an example of type 3 hypersensitivity reaction. But in the second scenario, where the antigen is fixed to the tissues, and then the antibody will react with this fixed antigen, this scenario is an example of type 2. Yes, type 2 hypersensitivity reaction. So in glomerulonephritis in general, in glomerular diseases, the mechanism of injury in certain cases can be of type 3 hypersensitivity reaction, and in other cases can be type 2 hypersensitivity reaction. In certain diseases, you can have both mechanisms at the same time, like in SLE, for example. In SLE, you can have glomerular disease due to mixed types of hypersensitivity reaction, type 3 and type 2. Then the final mechanism is cell-mediated immune mechanism. This is less common. Here, in the first 2 mechanisms, the immune reaction and the glomerular injury is mediated by antibodies. But here, this is cellular immune mechanism. That means this type of mechanism is mediated by T lymphocytes. It's not mediated by antibodies. And this is classically seen in minimal chain disease, as we said previously. There are autoreactive T cells, which release cytokines, and these cytokines it will not cause significant inflammation. It will not lead to inflammation in the glomerulus, but it can release and it can reduce the negative charge on the glomerular filtration membrane, and hence it will impair the charge barrier without affecting the size barrier. So minimal chain disease is one of examples of glomerular disease which is caused by cell-mediated immune mechanism, not antibody-mediated. So these are the main mechanisms by which glomerular disease can develop. So now let's talk about the different types of glomerulonephritis. The types of glomerulonephritis are morphological types. We generate these types according to the morphological features on histopathology. Because as we know, whenever you are suspecting a glomerular disease, the best way and the most accurate way to diagnose the condition is through kidney biopsy. You need to do kidney biopsy, and then you need to examine the biopsy specimen under microscope by different studies, as we will talk now. And according to the morphological changes that you will get, you can classify the type of glomerular disease you are dealing with, or glomerulonephritis. According to the morphology, you have 7 different types of glomerulonephritis. First, I would like to mention that the term glomerulonephritis is not always accurate, because in nephritis means there is inflammation. And there are certain cases of glomerular disease in which you might not detect significant inflammation in the glomerulus, or you might not detect even any inflammation at all. So in these cases, the term glomerulonephritis will be inaccurate. So more accurately, you can use the term glomerulopathy, which indicates just a disease affecting the glomerulus, whether this disease is inflammatory in nature or not. So the first morphological type, and one of the commonest types, is called minimal change disease. Minimal change disease is actually very common in pediatrics age, and also it's common in adults as well. In pediatrics, it represents around 75% of cases of nephrotic syndrome. In adults, it produces around 25% of nephrotic syndrome cases in adults. But what are these morphological changes which will be seen in minimal change disease? Before we talk about morphological changes, we want to know what are the studies which will be performed and done on biopsy. When you do biopsy, when you send the biopsy sample for the lab to the lab, what are the studies which will be performed and will help you to reach the exact morphological type of glomerulonephritis? There are three main studies. The first study is light microscopy. The second study is electron microscopy. And the third study is immunofluorescence studies. Each one of these will give you specific information. In the light microscopy, you will learn about the thickness of the glomerular basement membrane. And number two, you will know the degree of cellularity in the glomerulus. And these are very important changes. The thickness of the glomerular basement membrane tend to change in specific types of glomerulonephritis. And the degree of cellularity is very important because when you have more degree of cellularity, this increase in the cellularity might be due to proliferation of the local cells, like the mesangial cells, for example, and endothelial cells, or it might be due to infiltration by inflammatory cells, like neutrophils. And this might be seen in conditions associated with nephritic syndrome, when you have large number of neutrophils infiltrating the glomerulus, increasing the cellularity, detected on light microscopy. This might give you a clue that there is severe inflammation happening. So the light microscopic examination will give you information about the thickness of the glomerular basement membrane and about the degree of cellularity in the glomerulus. Then the electron microscopy will give you different information. The electron can detect electron-dense immunological deposits. As we said previously, as we discussed here in the pathogenesis, the pathogenesis is mainly depending on immune complexes. These immune complexes can be formed in the blood and then it will get trapped in the glomerulus, or it might be formed inside the glomerulus in the second example. These immune complexes, this antigen-antibody interaction along with complements activated, these are called immune deposits. And these immune deposits are electron dense. So they will be only detected by electron microscope. It will not be detected by light microscope. So when you do electron microscopic examination to the biopsy sample, you want to look for the immunological deposits. You want to detect where are these immunological deposits located within the glomerular filtration membrane, because the glomerular filtration membrane, as we said, consists of three layers: endothelium, basement membrane, and podocytes. Through the electron microscope, you can tell if there are immunological deposits in the glomerulus, and you can specifically tell where are these deposits located, at which layer. Is it under the endothelium, or is it under the epithelium, or is it inside the basement membrane? And according to that, you can differentiate between the different types of glomerulonephritis. Then finally, we have the immunofluorescence. The immunofluorescence studies, the electron microscope, as we said, it will show you the immunological deposits, but it will not tell you what are the specific components of these immunological deposits. This is the job of the immunofluorescence test. Immunofluorescence will tell you what are the exact components of these immunological deposits. Yani, the immunological deposits, is it consisting of IgG or IgM or IgA antibody? Is there any complement depositing or not? Sometimes it might not show you any antibody at all. And according to this information, you can know the difference between the different types of glomerulonephritis. For example, in IgA nephropathy, you will have the immune deposits consisting only of IgA antibodies. And this is not seen with the other types. So this will confirm the diagnosis of IgA nephropathy. So these are the different studies which will be made on biopsy: light microscopy, electron microscopy, and immunofluorescence. So we will apply each one of these to each type, morphological type. When we talk about minimal change disease, First, what are the clinical features in minimal change disease? In minimal change disease, the patient can present with subnephrotic range proteinuria or with nephrotic. We will talk about the clinical features later on, maybe in next session when we talk about each disease in more details. But now we would like to have an overview. We would like to know what is meant by minimal change disease. As the name implies, this is a glomerular disease in which there are minimal changes. You will not find a significant pathological changes under microscope. That's why this name is called minimal change disease. So in minimal change disease, first, when you do light microscopy, as we said, light microscopy should show you the thickness of the glomerular basement membrane and the cellularity. In minimal change disease, the light microscopic findings will be entirely normal. You will have normal glomerular basement membrane thickness, and you will have normal degree of cellularity when you do light microscopy. Then you proceed to do electron microscopy. In electron microscopy, you can only detect effacement of the podocytes food processes. The podocytes, as we talked about it here, the podocytes, which is forming part of the glomerular filtration membrane, these podocytes will become effaced. I will show you a picture here. Yes, here. This is a normal capillary. This is the podocyte, and these are their food process, as you can see. These are the food processes. Between them, you have filtration slit. This is a normal morphology of the podocytes. But in minimal change disease, as you can see, the food processes are not clearly seen. There is effacement or fusion of the podocytes, of the food processes of the podocytes. You cannot see these food processes clearly. And this problem, this pathological change, will immediately impair the charge barrier on the glomerular filtration membrane. And this is why it will allow the leak of albumin without other types of proteins. And this is the only pathological change which can be seen in minimal change disease. You will not detect any other significant inflammatory changes. You will not detect immunological deposits because in minimal change disease, as we said previously, it's cell-mediated. It's not mediated by antibodies. There are no antibodies. There are no complements. So you will not have immunological deposits. You will only detect fusion or effacement of the podocytes. And this will be detected on electron microscope, but light microscope will show you nothing. So this is the morphological finding in minimal change disease. So when you collect these features, when you find normal light microscope and on electron microscope, you only find effacement of the podocytes. This effacement of podocytes actually indicate early glomerular injury. Whenever you have a glomerular injury, the earliest change which will happen in the glomerulus will be effacement of the podocytes. But if it's only effacement of the podocytes without any other feature, this will put the diagnosis of minimal change disease. Then the second type, the second morphological type, is membranous glomerulonephritis. This is another important and common type also of glomerulonephritis. In membranous glomerulonephritis, when you do light microscopic examination, when you assess the thickness of the glomerular basement membrane, you find that the thickness is increased. There is increased thickness of the glomerular basement membrane. But the cellularity is normal. The degree of cellularity is normal. And this is very important because this is what will differentiate membranous from membranoproliferative on light microscopic examination. On light microscopic examination in membranous glomerulonephritis, only the thickness of the glomerular basement membrane will be increased, but the cellularity will remain normal, intact. But in membranoproliferative, the thickness is increased in the glomerular basement membrane as well as the cellularity is also increased under light microscopic examination. Then when we talk about the electron microscopic examination in membranous glomerulonephritis, here the condition is mediated by antibodies. There is antibody-antigen interaction. So you will detect an electron-dense immunological deposits. And these deposits will be detected specifically in the subepithelial surface of the glomerular filtration membrane. Subepithelial surface means that this is the surface between the surface underneath the podocytes, yani between the glomerular basement membrane and the podocytes. At this point, this is called the subepithelial surface.
معلش دكتور خالد، يلا الاندوثيليوم والبيزمي ممبرين والبودوسايت دي كلها الفيزرا اللاير حقت البومن كابسول؟
لا الفيزرا اللاير حقت البومن كابسول هي البودوسايتس بس. الاندوثيليوم والبيزمي ممبرين البيسمنت ممبرين هو
طبعاً
actually
glomerular.
fusion between البيسمنت ممبرين of the endothelium والبيسمنت ممبرين of the podocytes. عشان كده البيسمنت ممبرين the glomerular basement membrane is thicker normally compared to the basement membrane in other sites in the tissues in other tissues in the body يعني. Because it's due to fusion of two layers. Basement membrane of the endothelium and basement membrane of the epithelial layer اللي هي البودوسايتس. لكن strictly speaking, when you talk about the visceral layer of the Bowman's capsule, here we talk about the podocytes specifically, اللي هي outer part of the basement of the filtration membrane. So in membranous glomerulonephritis, you will detect the immunological deposits along the subepithelial surface of the glomerular filtration membrane, and you will have increase in the thickness of the glomerular basement membrane, but with normal cellularity. This on, as you can see here, this is a normal morphology of the glomerulus. يعني this is just sketch يعني to make it more clear. هنا this is the capillary lumen, وبره هنا this is the Bowman's space where the filtrate will be released. So we have three layers, as we said, endothelial layer, as you can see, فيها fenestration, فيها pores. Then we have in blue, we have the basement membrane. Then here, these are the podocytes with their food processes, as you can see. These are the three layers. This is a normal morphology, and this is the mesangial cell. Here in membranous glomerulonephritis or glomerulopathy, as you can see, the basement membrane is thicker compared to the normal basement membrane. But the cellularity is the same. Yani you cannot, there is no significant increase in the cellularity. You cannot see proliferation of endothelial cells. You cannot see significant proliferation in the mesangial cells or podocytes. You do not see infiltration by neutrophils. So the cellularity degree, the degree of cellularity is intact, is normal. But the thickness of the glomerular basement membrane, as you can see here in blue, is thicker compared to the normal morphology. And this is on light microscopy. Then when you go to electron microscopy, you will detect electron-dense immunological deposits, as you can see them here in black. These immunological deposits will be detected by electron microscopy because these are electron-dense. The electron microscopy, along with the immunofluorescence, they will not just detect, show you the site of the immunological deposits. They will also show you the pattern and the distribution of these deposits. As you can see, these deposits are deposited in granular manner. They are not in linear fashion. ما مرصوصات ورا بعض كده. في gap. There is a gap between every two deposits, as you can see. These gaps between the deposits will give a characteristic appearance called spike and dome appearance. Spike and dome. Yeah. This spike and dome appearance indicates these deposits are separated by gaps of basement membrane not containing deposits. And this is characteristic in membranous glomerulonephritis. So in membranous glomerulonephritis, you have increase in the thickness of the glomerular basement membrane. You have subepithelial, as you can see, the deposits are subepithelial. They are under the podocytes, under the epithelial layer here. The epithelial layer means the podocytes. Subepithelial immunological deposits, which gives a characteristic spike and dome pattern or appearance. Then on immunofluorescence, as you said, tells you what are the exact components in these immunological deposits. Immunofluorescence will tell you that these immunological deposits are consisting of IgG mainly, along with C3. There is activation of C3. It will not show you the antigen, of course, but it will show you the type of antibody, and it will show you the complement, which are activated at the site of the complex, the immune complexes. So you have C3 and IgG deposits along the subepithelial surface. These are the morphological. When you have this morphological picture, you will immediately put the diagnosis of membranous glomerulonephritis. Then the membranoproliferative glomerulonephritis, when you talk about the morphology specifically, under light microscope, you will have increase in the thickness of the glomerular basement membrane, similar to membranous, but here you will have increased cellularity. Yes, cellularity will be increased. The local cells will be proliferating, and there might be some recruitment of inflammatory cells, but mainly local cells. So more cells. The environment will be more cellular under examination compared to membranous. The finding on electron microscope immunological deposits في membranoproliferative, it depends on the type. Membranoproliferative, as we will talk later, it's divided into two main types, type 1 and type 2. In type 1, the immunological deposits are epithelial, and mesangial. In type 2, the immunological deposits are intramembranous. So an immunological deposits in membranous proliferative glomerulonephritis, it depends on the exact type. When you have type 1, membranous proliferative, we'll talk about it in more details. In type 1, you will have subendothelial deposits, and you will have mesangial deposits. So deposits will be, unlike here is subepithelial, but in membranous proliferative type 1, the deposits will be under the endothelium here. Under the endothelium, it will be subendothelial, and it will be in the mesangium here. So subendothelial and mesangial deposits in type 1 membranous proliferative. But in type 2 membranous proliferative, the deposits will be intramembranous. It will be inside the glomerular basement membrane. Intramembranous. So these are the basic differences between membranous proliferative and membranous glomerulonephritis. In focal segmental glomerulosclerosis, this is a special type of glomerulonephritis. Focal and segmental has specific meaning. In pathology, in nephrology, when you say focal is different from diffuse. And you compare focal to diffuse. Focal means that there is less than 50% of glomeruli affected. Yani when you do biopsy, less than 50% of the glomeruli are affected. This will be, the pathology will be considered focal. But if it's more than 50% affected, it will be called diffuse. And this is important to differentiate this from this. So in focal means that less than 50% of the glomeruli are affected. Segmental means when you look at a single glomerulus, when you look at the single tuft of glomerulus, in segmental, it means that the inflammation and the pathology is patchy. Yani it's not uniform. Yani you will have parts of the affected glomerulus showing the disease, but there are parts which will be spared. And part of the glomerulus will appear healthy and it will be spared, and part will be affected. So the disease is segmental. The disease is not uniform. It's patchy. And this is different than global. When you say the term global, global means the whole circumference of the single glomerulus is affected. But segmental means, in the single glomerulus, part of the glomerulus will be affected by the disease and part of it will be normal. It will not be affected. So this is what means by focal segmental glomerulosclerosis. Sclerosis, nephrologists in general, they use the term sclerosis instead of fibrosis. They use sclerosis or hyalinosis or hyalinization. So sclerosis or hyalinization, basically, in nephrology, it means fibrosis and scarring. So in this disease, it means that there is a scarring of the glomeruli. And since there is a scarring, logically, you can tell that this disease has a tendency to progress into chronic kidney disease. So it's a chronic pathology. So you're not expected to present as nephritic syndrome because nephritic syndrome is acute. So from the name here, you can understand that focal segmental glomerulosclerosis is a slow developing disease which present with proteinuria more likely and eventually can lead to chronic kidney disease. But it will not present acutely with nephritic syndrome and acute kidney injury because there is sclerosis. So this sclerosis, it will be focal, and it will affect less than 50% of the glomeruli, and it will be segmental, and it has patchy involvement of the glomerulus. It will not affect the whole affected glomerulus. So, these are the morphological findings in this disease, focal segmental glomerulosclerosis. Then in the diffuse proliferative glomerulonephritis, again from the name, diffuse means that most of the glomeruli are affected. So this disease is affecting large portion of the kidney, affect large portion of the glomeruli in the kidney, because the disease is diffuse, meaning that more than 50% of the glomeruli are affected, and it's proliferative. So that means on light microscopic examination, you will have an increased degree of cellularity, and here you will have infiltration by neutrophils. The glomeruli will be infiltrated heavily with inflammatory cells, and that's why it's called proliferative. I have a histology picture, I think, here. Yes, as you can see here, this is the glomerulus. As you can see, the Bowman's space where the filtrate will be released and is not clear here because the glomerulus is heavily infiltrated by neutrophils. As you can see, these eosinophilic dots all over the glomerulus. These are neutrophils, and along with that, also there is local proliferation of cells. The endothelial cells are proliferating the mesangial cells are proliferating, and the disease is diffuse. As you can see, surrounding the whole area, there are neutrophils infiltration. So this indicates that the disease is diffuse and the disease is proliferative. So the name is diffuse proliferative glomerulonephritis. And actually, this is the commonest type of lupus nephritis. Lupus nephritis has different types. This is the commonest one. And also, this is the pattern of glomerulonephritis seen with post-streptococcal glomerulonephritis. So diffuse proliferative glomerulonephritis. In diffuse proliferative glomerulonephritis also, on light microscopy, as we said, there is increased cellularity. This is the clear finding. On electron microscopy, you will have also an immunological deposits, which will be subepithelial. Subepithelial immunological deposits, similar to membranous. They call it subepithelial humps. Subepithelial humps. It's located in the subepithelial surface, similar to membranous glomerulonephritis. These are the immunological deposits in the diffuse proliferative glomerulonephritis. Then in the sixth type, called mesangioproliferative glomerulonephritis, this is characteristic of IgA nephropathy. And IgA nephropathy actually is the commonest cause of glomerulonephritis worldwide. It's an important disease. And it's called IgA nephropathy, but on morphology, when you do biopsy, the morphological type of glomerulonephritis is mesangioproliferative glomerulonephritis. Again, from the name, you can really understand what is happening. Mesangioproliferative, that means this disease, there is proliferation, the cellularity is increased on light microscopy, and this increase in cellularity is mainly originating from the mesangium. So the main cells that are proliferating here are the mesangial cells. And when you do electron microscopy in this disease, you will find an electron-dense immunological deposit which are located on the mesangium. And on immunofluorescence, these immunological deposits will be found to be formed of IgA immunoglobulins. So when you have all this information together, you will put the diagnosis of IgA nephropathy, and it's an important type of glomerulonephritis. I don't know if I have a picture here. Show it. Yes, okay, here. As you can see, this is tuft of glomerulus. You see here, the darker areas here is due to expansion and proliferation of the mesangium. Remember, the mesangial cells are located between the capillaries, between the glomerular capillaries. So the mesangial cells here are proliferating around the glomerular capillaries. These are the spaces of the glomerular capillaries, but the mesangium, here there is proliferation of the mesangium, and this indicates IgA nephropathy. On immunofluorescence, it will show you an IgA deposits along the mesangium. Focus here, proliferation and hypercellularity of the mesangium in the glomerulus. The final morphological type is called crescentic glomerulonephritis. Crescentic glomerulonephritis, this is the morphological type, but clinically, it's named rapidly progressive glomerulonephritis. This rapidly progressive glomerulonephritis is the term applied to those patients who develop an acute renal failure that develops and progresses over days or weeks, along with presence of crescents on renal biopsy. And when you do in patient with acute kidney injury, when you do renal biopsy and you find that the patient is having characteristic crescents on the glomeruli, you would put the diagnosis of rapidly progressive glomerulonephritis. What do we mean by these crescents? In this situation, remember when I talked about the clinical manifestation, I said that there are certain types of glomerular diseases which has a tendency to present with acute kidney injury from the start. And this is actually classically seen with this type of glomerulonephritis, which is called crescentic glomerulonephritis. In this type, the inflammation is so severe. It's more severe than any other type of glomerulonephritis. So logically, you would expect when you have such severe inflammation and acute inflammation, you would expect this patient to present with acute and dramatic presentation. So they will present with acute kidney injury from the beginning. And the inflammation is so severe, there is recruitment and infiltration of the glomerulus by a large amount of inflammatory cells, along with proliferation of local cells. Then these inflammatory cells will start releasing some important inflammatory mediators. They will start releasing proteolytic enzymes. They will start releasing cytokines, they will start releasing growth factors. And some of these growth factors will act on the parietal layer of the, remember, this is called the parietal layer of the glomerular of the Bowman's capsule. The growth factors which are released here in the inflammation seen in this condition will stimulate these epithelial cells of the parietal layer of the Bowman's capsule. And these cells will start proliferating excessively. And when they proliferate, these cells will proliferate from outside to inside. And they will start obliterating the space here. They will obliterate the Bowman's space. And so there will be no enough space left for the glomerular, for the filtrate to be released. So logically means that when this space is completely obliterated or significantly obliterated, means that the glomerular filtration rate will be significantly reduced. And for that reason, these patients will present with acute kidney injury because these cells are proliferating heavily and excessively, obliterating the Bowman's space or the urinary space, and hence they will impair the glomerular filtration. So they will reduce the glomerular filtration rate. And this proliferation of these cells, as you can see here, normally, this space, if you try to draw the Bowman's space, you will have the shape of crescent, as you can see, normally. So if these cells have filled this space, it will take the crescent shape of the normal space. And for that reason, it will be called crescentic glomerulonephritis. This is a name given after the shape of these cells obliterating the Bowman's space. As you can see here in this picture. Here, this is a very important picture. This is the glomerulus infiltrated heavily by inflammatory cells. And this should be the Bowman's space normally, but it's obliterated by parietal cells. As you can see, it's giving a crescentic shape, as you can see, surrounding the glomerulus. Another picture, again, around the glomerulus, as you can see here. These are the proliferating parietal layer of the Bowman's capsule, which will give you crescentic shape. So this is a glomeruli full of crescents. This picture is very important, especially for MRCP, commonly encountered in MRCP Part 2 exams. They will give you a scenario of a patient with glomerular disease, patient presenting with acute kidney injury, which has progressed over days. And they show you that the patient is having maybe microscopic hematuria. And they will not give you any evidence of any other source of acute kidney injury, and you will not have features suggestive of prerenal causes or postrenal causes. So you think that this is an intrinsic kidney disease, it's an intrarenal cause, especially if there is active sediments in the urine, if there is microscopic hematuria on the urine. So they might ask you what investigation to do, or they might tell you that the patient renal biopsy was requested, and this is the picture of the histopathology, and they will give you the slide. It's a common scenario. From the scenario you can tell sometimes in Part 2 exams, the scenario can tell you a lot. You might go to the picture. When you look at the picture, you will anticipate what you are looking for. You might solve the problem from just the scenario, or sometimes you might need to diagnose the picture. So it's important to memorize this picture very well of crescentic glomerulonephritis. If you need to memorize only one slide from glomerulonephritis, just memorize this one. So this is called rapidly progressive. Clinically, it's called rapidly progressive glomerulonephritis, but morphologically, it's called crescentic glomerulonephritis, and this is the most aggressive type of glomerulonephritis, and it has certain causes. We will talk about it later on. This picture diagram is showing the different clinical presentation with different types, morphological types that we talked about it. As you can see, if certain types will present with nephritic syndrome, and there are certain types will present with nephrotic syndrome, and there are types which will present with a mixed nephritic-nephrotic picture. Those that present with nephrotic syndrome include minimal change disease, membranous, focal segmental, amyloidosis, and diabetic nephropathy. Those that present with nephritic syndrome include rapidly progressive IgA nephropathy, Alport syndrome, and we have conditions which can present with nephritic plus nephrotic at the same time, like diffuse proliferative membranoproliferative and positive to coccal. We will come back to this figure next when we talk about specific types of glomerulonephritis in the next session. But before that, let's talk about the etiology. What are the possible causes of glomerular disease? As we said, our discussion today يكون backward. We started with the clinical features, then we talked about the pathogenesis, then we talked about the types, and then we will come to the etiology. In normal circumstances, we should start with the etiology, but here, عشان everything to be clear, we went backward. The etiology, what are the conditions, the causes, which can cause one of these mechanisms, can cause glomerular injury by one of these mechanisms, leading to one of these clinical features and leading to one of these morphological features eventually on biopsy. So when you go backward to the etiology, in a lot of cases of glomerulonephritis, the cause cannot be identified and the condition will be considered idiopathic. And this will be labeled as primary glomerulonephritis. You might have a patient presenting with nephrotic syndrome, nephrotic range proteinuria and all the features. You do biopsy. On the biopsy, you found that the patient is having membranous glomerulonephritis according to the findings. Then you do a lot of investigations in order to look for possible secondary causes for membranous glomerulonephritis, but you did not detect anything. So you will label the patient as having idiopathic membranous glomerulonephritis, or you can call it primary membranous glomerulonephritis, like that. So عشان كده a lot of time you have patient diagnosed with one of these morphological disease. It'll just tell you that the patient is diagnosed with membranous glomerulonephritis. That means that the condition is idiopathic. It's not secondary. So it's not just enough to know, to diagnose someone. Nephrotic syndrome or nephritic syndrome, this is not a diagnosis. This is a clinical presentation. This is not enough. If you have nephritic or acute kidney injury and you think this acute kidney injury is intrarenal, you should know the exact morphological type. For example, you say that this is nephrotic syndrome due to membranous glomerulonephritis, and this is also not enough. The next step, you need to know the cause of membranous glomerulonephritis, if there is any cause. If there is a cause, you will call it secondary membranous glomerulonephritis. You will say that this is nephrotic syndrome due to secondary membranous glomerulonephritis. But if the cause is not known, you will say this is idiopathic membranous glomerulonephritis. So what are the secondary causes which can be detected in some cases of glomerulonephritis? These secondary causes can be infections. Remember, we said that in a lot of cases, يكون في antigen antibody interaction. And this antigen sometimes can be of infectious origin. It might be an infectious antigen. It might be bacterial, it might be viral, it might be parasitic, for example. There are a lot of infections that have been linked with glomerulonephritis. For example, we have HIV, and HIV is classically linked with focal segmental glomerulosclerosis. Then we have hepatitis B, and this is classically linked with membranous. Yes. And we have hepatitis C. This is classically with membranoproliferative type 1.
Yes.
Then we have non-viral, we have bacterial, and the most important, overall, the most important bacterial disease associated with glomerulonephritis is bacterial endocarditis, especially subacute bacterial endocarditis. Here, this is the important bacterial cause associated with glomerulonephritis. There are other bacterial conditions, spirochetal infection like syphilis, for example, also leprosy, برضو has been linked with glomerulonephritis. Then we have protozoal infections like malaria and like schistosomiasis. Malaria and schistosomiasis are important in endemic regions as possible cause of glomerulonephritis. And malaria specifically, Plasmodium malariae species. Yes, malaria is specifically associated with glomerulonephritis, although nowadays it's rare. It's not commonly found. But still, it's a reported cause of association with nephrotic syndrome. So these are possible infectious infections associated with glomerulonephritis, glomerular disease in general. Then we have drugs. Again, drugs can act like antigen, which can lead to formation of immune complexes or can get planted in the glomerular membrane, and then this can trigger an inflammatory reaction. These drugs, a classical example are the old anti-rheumatoid drugs like gold and penicillamine. Also, non-steroidal anti-inflammatory drugs. There are other drugs like lithium, rifampicin, has been linked also There are many drugs, but classical and actually commonly also encountered in the exams are these three: gold, penicillamine, and non-steroidal anti-inflammatory drugs. Then important also etiological factor, especially in membranous glomerulonephritis, malignancy. We should always try to exclude malignancy, especially in cases of membranous glomerulonephritis. And this malignancy can be, for example, carcinomas, like lung cancer, for example. And this common scenario actually in the exam also, they give you a scenario of some old patient, ex-smoker maybe, had a history of hemoptysis, and now he presented with generalized body edema, or he was found to have nephrotic syndrome. And they will ask you, what is the most likely finding on renal biopsy? Here, most likely will be membranous glomerulonephritis, because this is the common type of glomerulonephritis associated with malignancy. Malignancy always linked with membranous glomerulonephritis. It could be carcinomas, or it could be hematological malignancies like lymphoma, multiple myeloma, and so on. Remember that also with multiple myeloma, there might be amyloidosis, and amyloidosis is an important cause of glomerulonephritis as well. Then finally, we can have chronic systemic diseases, which can be associated with glomerulonephritis. And this is very important etiology, which should be excluded. The most important one you can think of are diabetes and SLE. They can affect the kidneys in different ways. So diabetes, usually they present with diabetic nephropathy, tend to have a slow insidious course that develops over many years. Initially, the patient will have microalbuminuria. There will be hyperfiltration. The glomerular filtration rate in the early stage will be increased. And there will be a microalbuminuria for many years. And then you will have macroalbuminuria. You will have severely increased albuminuria, until eventually the patient will start to have characteristic morphological findings like Kimmel-Steele Wilson nodules. On biopsy, you will have glomerular sclerosis with nodules on biopsy, and the patient at the end will go on to develop end-stage renal disease. So it's an important cause of glomerular disease, and the patient might present with, these are the classical patients that tend to present for many years with this first presentation: asymptomatic subnephrotic range proteinuria. Then we have SLE. SLE has different stages of lupus nephritis. We will not go into details of it, maybe on different occasion, because it will not end on SLE. But remember, SLE can give you different morphological picture. It can present, for example, with membranous glomerulonephritis, or it can present with diffuse proliferative, and this is the most common form of lupus nephritis, diffuse proliferative glomerulonephritis, until eventually SLE can also lead to end-stage renal disease. And as we said previously, all of these clinical features eventually can end on chronic kidney disease if the condition is unresolved and not controlled. If you did not control diabetes strictly early enough, the patient eventually will go on into chronic kidney disease. And remember, diabetic patients who are having glomerular disease, diabetic nephropathy, most likely, especially type 1 diabetes, they will have other evidence of diabetic vasculopathy or microangiopathy. They will have retinopathy, for example, neuropathy, and so on. Then another important systemic disease is amyloidosis. Amyloidosis, it could be primary, it could be secondary reactive to chronic inflammatory diseases, like rheumatoid arthritis, for example, or with multiple myeloma. It has a lot of possible secondary causes. We will not also go into details of it, but amyloidosis also can present as membranous glomerulonephritis. Actually, the secondary causes here, membranous glomerulonephritis is the most likely among the different morphological types to have an underlying cause, to have a secondary cause. And when you have a membranous glomerulonephritis, always try to do your best to look for secondary cause, because it's more likely compared to the other types to have secondary cause. So these are the possible etiologies for glomerular disease. I think it's enough for now. We will try to complete our discussion in next occasion after a few days. But we'll talk in more details about specific each one of these diseases. We will go through the same things that we discussed now, and we will talk in more details about the treatment, how we will address each one of these. But as a general rule, in the management and the treatment of glomerulonephritis, first you need to do supportive treatment. Supportive treatment meaning that symptomatic treatment, and that means the treatment of nephrotic and nephritic syndrome. And then after that, you will give specific treatment. The specific treatment depends on whether it's primary or secondary. If it's secondary, meaning that there is one of these etiological factors, you need to treat the underlying cause. But if it's primary, you will not have an underlying cause. So what you will do is you will control the immune system, because as we said, glomerulonephritis is always immune-mediated injury. So if you cannot find an underlying cause to control, you will control the immune system. You will give immunosuppressive therapy. You will give corticosteroids, and sometimes you can give other immunosuppressive therapy like alkylating agents, for example, like cyclophosphamide, chlorambucil. You can also sometimes consider steroid-sparing drugs, and so on. So these are the general management of glomerular disease. In the next lecture, we will talk about in more details about the management of nephrotic syndrome and the management of nephritic syndrome, and about in more details about each one of these types. Any questions? I hope everything is clear.
طيب, I believe you cover everything, Dr. Khalid. يعني special thanks and appreciation for providing us with this great lecture. يعني حاجة عظيمة جدا جدا. جزاك الله خير.
شكرا لكم كلكم لحضوركم طبعا في رمضان في ناس بتكون مشغولة وكده والوقت متأخر، لكن شكرا جزيلا على حضوركم جميعا، حسن استماعكم. وزي ما قلت لكم يعني this is not the whole talk. يعني I tried انه اخلي الليكشر على two sessions. The next session ان شاء الله we will complete the rest of our talk. بس الجلوميرولار ديزيز هو بس لانه شويه ممكن يكون complicated topic وما مدينه حقه يمكن في النوتس وفي عموما في الماتيريالز، و it's important for the exam. يعني all the board exams عموما especially MRCP whether part 1 or part 2. Questions regarding glomerular disease are very common, and it's linked with other systems. It's linked with rheumatology as well, linked with other malignancy, as we know, with hematological malignancies. So scenarios not just limited to nephrology. It's also ممكن تكون linked with rheumatology, with hematology, and other systems.
يديك العافية يا دكتور خالد، جزاك الله خير، كل عام وانتم بخير يا أخي.
عفوا وانتم بخير، رمضان كريم عليكم جميعا.
الله يبارك فيك يا أخي.
جزاك الله خير والله. حاضر الجميع.
شكرا لكم. If anyone has any question ما محضره حاليا ممكن on the next session to address it to try to discuss it إن شاء الله.
شكرا يا دكتور، جزاك الله كل خير.
تسلم.
نستأذنكم.
طيب شكرا كثير دكتور خالد، شاكرين جدا.
عفوا شكرا لكم كلكم.
الله
توفيق إن
يخليك.
شاء الله.
شكرا.
السلام عليكم.
شكرا يا شباب، شكرا لكم كلكم.
عليكم السلام. شكرا يا دكتور، جزاك الله خير.
الله يخليك يا رب.